Today we are going to cover nursing management of the postpartum woman at risk. Numerous adaptations and adjustments must be made to assimilate the newborn into the established family unit. It is a time designed for maternal recovery, family attachment, and new role development. Typically, recovery from childbirth progresses normally, both physiologically and psychologically. However, the woman can experience deviations from the norm, developing a postpartum condition that places her at risk. These high-risk conditions or complications can become life-threatening. Postpartum hemorrhage is a potentially life-threatening complication that can occur after both vaginal and cesarean births. It is the leading cause of maternal death in both developed and developing countries, accounting for about 35% of all maternal deaths. A hemorrhage occurs in 5% of all births and is responsible for a major part of maternal mortality. The majority of these deaths occur within 4 hours of childbirth, which indicates that they are a consequence of the third stage of labor management. Postpartum hemorrhage is defined as a blood loss greater than 500 milliliters after vaginal birth or more than 1,000 mLs after a cesarean birth. Morbidity from postpartum hemorrhage can be severe, with sequelae including organ failure, shock, edema, thrombosis, acute respiratory distress, sepsis, anemia, intensive care admission, and prolonged hospitalization. A major obstetric hemorrhage is defined as a blood loss of more than 1,500 to 2,500 mLs, or bleeding that required more than 5 units of transfused blood. Timely, accurate identification and initiation of appropriate interventions would improve outcomes. Pathophysiology. The pathophysiology of postpartum hemorrhage includes excessive bleeding that can occur at any time between the separation of the placenta and its expulsion or removal. Causes: uterine atony, failure of the uterus to contract and retract after birth, is one of the major causes of postpartum hemorrhage. The uterus must remain contracted after birth to control bleeding from the placental site. Uterine atony is responsible for 80% of primary or immediate postpartum hemorrhage, while obstetric lacerations, uterine inversion, and rupture comprises about 20% of all primary or early postpartum hemorrhages. A full bladder is also sometimes a cause. The 4 main causes of postpartum hemorrhage relate to the 4 T's: tone, tissue, trauma, and thrombin. Under tone, again we refer to the uterine atony, a distended bladder which displaces the uterus from the midline to either side, which impedes its ability to contract to reduce bleeding. Tissue. Tissue would be the failure of complete placental separation and expulsion, which leads to retained fragments, which occupy space and prevent the uterus from contracting fully to clamp down on blood vessels. This can lead to hemorrhage. Subinvolution refers to the incomplete involution of the uterus, or failure to return to its normal size and condition after birth. Trauma. Lacerations and hematomas resulting from birth trauma can cause significant blood loss. And thrombin. Disorders of coagulation are relatively uncommon as a sole cause of postpartum hemorrhage. Thrombosis, which is a formation of a blood clot, helps to prevent postpartum hemorrhage immediately after birth by providing hemostasis. Fibrin deposits and clots in supplying vessels play a significant role in the hours and days after birth. Disorders that interfere with the clot formation can lead to postpartum hemorrhage. DIC, or disseminated intravascular coagulation, is a life-threatening acquired coagulopathy in which the clotting system is abnormally activated, resulting in widespread clot formation in the small vessels throughout the body, which leads to the depletion of platelets and coagulation factors. DIC is not itself a specific illness. Rather, it is always a secondary diagnosis that occurs as a complication of abruptio placenta, amniotic fluid embolism, intrauterine fetal death with prolonged retention of the fetus, acute fatty liver of pregnancy, severe preeclampsia, HELP syndrome, septicemia, and postpartum hemorrhage. Clinical features include petechiae, ecchymosis, bleeding gums, fever, hypotension, acidosis, hematomas, tachycardia, proteinuria, uncontrolled bleeding during birth, and acute renal failure. Therapeutic management. Prompt diagnosis and understanding of the underlying triggers of this complication is essential for a favorable outcome. Therapeutic management focuses on the underlying cause of the hemorrhage. Delayed postpartum hemorrhage may occur despite adequate prophylaxis. Frequent monitoring and continued prophylaxis and/or treatments are recommended for at least 2 weeks after childbirth. Nursing assessment. The primary prevention of a postpartum hemorrhage begins with an assessment of the identifiable risk factors. The period after the birth and the first hours postpartum are crucial times for the prevention, assessment, and management of bleeding. Bleeding can rapidly become life-threatening, and nurses, along with other healthcare providers, need to identify this condition quickly and intervene appropriately. Begin by reviewing the mother's history. Include labor and birth history for risk factors associated with postpartum hemorrhage. Although specific risk factors have been identified, postpartum hemorrhage is often unanticipated and still occurs in approximately 5% of all births and is increasing. On table 22.2, you will see the clinical manifestations of shock due to blood loss. And this table is a very good representation of the signs and symptoms that a patient will demonstrate when they have the 3 degrees of shock: mild, moderate, and severe. This is a table that you should be looking into and studying while we are assessing for the identifiable risk factors, or for assessing for symptoms of postpartum hemorrhage. Therapeutic management. Well, let's go back a little bit to nursing assessment. Primary prevention of a postpartum hemorrhage begins with an assessment of identifiable risk factors, and that is what we just discussed. The period after birth and the first hours postpartum are crucial times for the prevention and assessment and management of bleeding. Bleeding and the amount of bleeding needs to be assessed. Visual estimation is the most frequently practiced method of determining blood loss during childbirth in the U.S., and the results are usually included in the documentation of events pertaining to the birth. However, this is changing in practice, and we are now quantifying our the bleeding that a patient has by weighing the actual supplies that are used to absorb the blood, and being able to get a much better quantification of blood loss rather than just an estimation of blood loss. If trauma is suspected, attempt to identify the source, and documenting it is also very important. Therapeutic management. Prompt diagnosis and understanding of the underlying triggers of this complication is essential for a favorable outcome. Therapeutic management focuses on the underlying cause of the hemorrhage. Delayed postpartum hemorrhage may occur despite adequate prophylaxis. Frequent monitoring and continued prophylaxis and/or treatments are recommended for at least 2 weeks after birth. When excessive bleeding is encountered, initial management steps are aimed at improving uterine tone with immediate fundal massage, intravenous fluid resuscitation, and administration of uterotonic medications. If these methods fail to control bleeding, additional resources are mobilized, and more aggressive interventions such as bimanual compression, internal uterine packing, and/or balloon tamponade techniques are employed by the healthcare provider. On your drug guide in 22.1, you will see the most common drugs that are used to be able to help control postpartum hemorrhage. Oxytocin or Pitocin is, of course, your first line therapy, and that will stimulate the uterus to contract to contract the uterus to control bleeding from the placental site. Misoprostol or Cytotec is your second line, and that will also stimulate the uterus to contract to reduce bleeding, and it is a prostaglandin analog. Dinoprostone, which is also a prostin, it is a vaginal or rectal suppository, and this may be repeated every 2 hours. You have methylgenovolin maleate, which is also known as Methergin, and that will stimulate the uterus to prevent and treat postpartum hemorrhage due to atony or subinvolution. And lastly, we have your prostaglandin carboprost, which is known as Hemabate, and Hemabate also helps to stimulate the uterine contractions to treat postpartum hemorrhage that is due to uterine atony when not controlled by any other methods. So it is a third line medication. You will be at least responsible for knowing your first line, second line, and your third line medications. The medications here on this table are your most common meds that are given, and at least should be known as medications known for treating postpartum hemorrhage. Venous thromboembolism is one of the leading causes of maternal mortality and morbidity, with an annual incidence of 1 per 1,000 pregnancies, a 10 times higher risk than the non-pregnant population. A thrombosis, which is a blood clot within a blood vessel, can cause an inflammation of the blood vessel lining, which is known as thrombophlebitis, which in turn can lead to a thromboembolism, which is an obstruction of a blood vessel by a blood clot carried by the circulation from the site of origin. DVT is a common condition that can have serious complications. Deep venous thrombi have a high probability of propagating and leading to pulmonary emboli, which may cause chest pain, breathlessness, and sudden death. The three most common venous thromboembolic conditions occurring during the postpartum period are superficial venous thrombosis, DVT, and PE. A thrombus, which is a blood clot, formation typically results from venous stasis, injury to the innermost layer of the blood vessel, and hypercoagulation. Venous stasis and hypercoagulation are both common in the postpartum period. If a clot dislodges and travels to the pulmonary circulation, a PE can occur. A pulmonary embolism is a potentially fatal condition that occurs when the pulmonary artery is blocked by a blood clot that has traveled from another vein into the lungs, causing an obstruction and infarction. Only 25% of all clients with PE are actually diagnosed, indicating that thousands of PEs go undetected. Many deaths due to PE are unrecognized, and the diagnosis is often made at autopsy. PE is the leading cause of pregnancy-related death in the United States, occurring in 2 out of 100,000 live births. It most commonly occurs up to 3 weeks postpartum and following a surgical birth. Nursing assessment. Assessing the woman closely for risk factors and signs and symptoms of thrombophlebitis is of major importance. Look for risk factors in the woman's history: use of oral contraceptives before the pregnancy, smoking, employment that necessitates prolonged standing, history of thrombosis, thrombophlebitis, or endometritis, or evidence of current varicosities, prolonged bed rest, diabetes, obesity, cesarean birth, a progesterone-induced distensibility of the veins of the lower legs during pregnancy, severe anemia, varicose veins, advanced maternal age, older than 35, and multiparity. These all are risk factors in a woman's history that can lead them to a PE. Ask the woman if she has pain or tenderness in the lower extremities. Suspect superficial venous thrombosis in a woman with varicose veins who reports tenderness and discomfort over the site of the thrombosis, most commonly in the calf area. Be alert for signs and symptoms of pulmonary embolism, including unexplained sudden onset of shortness of breath and severe chest pain. The woman may be apprehensive and diaphoretic. Additional manifestations may include tachycardia, tachypnea, hypotension, syncope, distension of the jugular vein, decreased oxygen saturation, shown by the pulse oximetry, cardiac arrhythmias, hemoptysis, and a sudden change in mental status as a result of the hypoxemia. Nursing management is going to focus on preventing thrombolytic conditions, promoting adequate circulation if thrombosis occurs, and educating the client about preventative measures, anticoagulant therapy, and danger signs. Measures to help prevention. Prevent thrombolytic conditions. Public awareness is going to be, of course, a good starting point. Preventing venous stasis, which helps, and by doing that you would help to promote activities that causes leg muscles to contract and promotes venous return. Dorsi or plantar flexion of the feet with prolonged sitting to help promote venous return as well are all ways that you can help to prevent thrombotic conditions. Promoting adequate circulation can be done and is usually the mainstay of venous thromboembolic conditions is going to be anticoagulation, while interventions such as thrombolysis and inferior vena cava filters are reserved for limited circumstances. For the woman with superficial venous thrombosis, administer NSAIDs for analgesia. Provide for rest and elevation of the affected leg. Apply warm compresses to the affected area to promote healing. And use anti-embolism stockings to promote circulation to the extremities. Implement bed rest or limited ambulation if ordered, and elevation of the affected extremity for the woman with a DVT. Educate the client. The teaching guidelines in 22.1 will give you a really well scenario of what you would teach to prevent bleeding related to anticoagulant therapy. You want to provide anticipatory guidance, support, and education about the associated signs of complications and risk that can occur. So watch for possible signs of bleeding and notify your healthcare provider if any do occur, like nosebleeds, bleeding from the gums or mouth, black tarry stools. Practice measures to reduce your risk of bleeding, so brushing your teeth with gently with use of a soft toothbrush. Use an electric razor for shaving. You want to be able to be sure to comply with the follow-up laboratory testing that's scheduled. If you accidentally do cut or scrape yourself, apply firm direct pressure to the site for about 5 to 10 minutes, and do the same after receiving any injections or having blood specimens drawn. So this teaching guide is in your book, and it also, like I said, it does help you a lot with knowing teaching methods or teaching points that you should include in your patient education. Postpartum infections. Infection during the postpartum period is a common cause of maternal morbidity and mortality. There is a higher occurrence in cesarean births than in vaginal births. Postpartum infection is defined as a fever of 100.4 or greater after the first 24 hours after childbirth, occurring on at least 2 of the first 10 days after birth, exclusive of the first 24 hours. Risk factors that would place a patient at higher risk for a postpartum infection would include surgical birth, if the patient has prolonged rupture of membranes, if the patient had long labor with multiple vaginal examinations, if they have inadequate hand hygiene, if they had internal fetal monitoring, uterine manipulation, chorioamnionitis, an instrumental birth like with a vacuum or forceps, and if they have obesity. Also included in this list of risk factors would be untreated infections prior to birth, retained placental fragments, gestational diabetes, extremes of client age, so you're very young, younger than 15, or you're very old, older than 35, lower socioeconomic status, and anemia during pregnancy. Metritis, which are this will fall under your most common infections, although we usually refer to it as clinically as endometritis. Postpartum uterine infections typically involve more than just the endometrial lining. So we use the term metritis to signify an infectious condition that involves the endometrium, the decidua, and adjacent myometrium of the uterus. The uterine cavity is sterile until rupture of the amniotic sac. So as a consequence of labor, birth, and associated manipulations, anaerobic and aerobic bacteria can contaminate the uterus. The risk of metritis increases dramatically after a cesarean birth. It complicates from 10 to 20% of all cesarean deliveries. This is typically an extension of chorioamnionitis that was present before birth. Indeed, that may have been even why the reason the patient had a cesarean delivery in the first place. Surgical site infections are any break in the skin or mucous membranes provides a portal for bacteria. Sites of wound infection include cesarean surgical incisions, the episiotomy site in the perineum, or any genital tract lacerations. Urinary tract infections, also one of your most common infections. They're more commonly caused by the bacteria often found in bowel flora, including E. coli, Klebsiella, Proteus, and Enterobacteria species. These are usually treated and have very little morbidity. Mastitis, is also defined as an inflammation of the mammary gland, a common problem that may occur within the first 2 days to 2 weeks postpartum, and that is usually an inflammation of a milk duct or mammary gland caused by clogged milk. And it's due usually for those moms who are either breastfeeding or non-breastfeeding. Nursing assessment is going to include that the primary caregivers for postpartum women have a very unique opportunity to identify subtle changes that take place or that would place women at risk for an infection. Because these perinatal nurses are doing regular postpartum exams or postpartum checks on their patients, they're able to pick up any subtle changes rather quickly. Nurses play a key role in identifying the signs and symptoms that suggest a postpartum infection. Nurses must assess the new mothers for risk factors and identify early, subtle signs and symptoms of an infectious process. Review the client's history and physical examination and labor and birth record for factors that might increase her risk for developing any infection. Assessments of the bubble and assess for signs and symptoms of infection are vital. In your book, you also have a table that shows you your signs and symptoms of a postpartum infection, and that would include symptoms and signs and symptoms of metritis, signs and symptoms of wound infection, your signs and symptoms of a urinary tract infection, and your signs and symptoms of mastitis. This is clearly spoken of in your book, and you should use this slide to help you learn these most common signs and symptoms of these infections. Therapeutic management for these most common infections would include broad spectrum antibiotics for metritis. You want to measure to help to restore and promote fluid intake. You want to make sure you have an electrolyte balance. Provide analgesia for your patient. And you want to provide emotional support as well. For your surgical site infections, therapeutic management will include involving the recognition of the infection. You want to open the wound to allow for drainage, aseptic wound management, hydration, ambulation to prevent venous stasis, and also analgesics. For UTIs, common during postpartum period and could be prevented by timely removal of a urinary catheter used during labor or any surgical births. Baycare now has a protocol that all Foleys are to be removed within 12 to 24 hours after the delivery of the infant, especially if it's a C-section patient. Risk factors would include, of course, having a catheter, patients with an epidural anesthesia, patients with any vaginal procedures. Fluids are going to be used to treat any dehydration. You want to provide vitamin C and cranberry juice, which will help them with good probiotics. Patients with mastitis, you do want to focus on 2 areas for treatment, making sure that the breasts are emptied and from milk, and you want to control the infection. You want to continuous and frequent bleed and feeding, so you don't want them to stop breastfeeding. You want them to continue breastfeeding because that will help to continue the flow of milk through the milk glands. You want to provide them antibiotic therapy, symptomatic treatment. So you want to provide symptomatic treatments for their symptoms. So warm compresses, topical lotions, things like that. Reassurance, emotional support, and lots of education are what's going to help these women get through this process. If the woman develops an infection, review the treatment measures, such as antibiotic therapy if it's ordered, and any other special care measures, such as dressing changes, that might be also needed. So you want to make sure that lots of education to let them know what is happening and what's going on and what is going to be the plan of care is vital for their progression and for their improvement. Postpartum affective disorders. The postpartum period involves extraordinary physiologic, psychological, and socio-cultural changes in the life of a woman and her family. Typically, the delivery of a newborn is associated with positive feelings such as happiness, joy, and gratitude for the birth of the healthy infant. However, women may also feel weepy, overwhelmed, or unsure of what is happening to them. They may experience fear about loss of control. They may feel scared, alone, or guilty, or as if they have somehow failed. Many types of affective disorders occur in the postpartum period. Although their description and classification may be controversial, the disorders are commonly classified on the basis of their severity as postpartum or baby blues, postpartum depression, and postpartum psychosis. So we start with postpartum blues. The woman experiences rapid cycling mood symptoms during the first postpartum week, and this is typical. Women exhibit mild depressive symptoms of anxiety, irritability, mood swings, tearfulness, increased sensitivity, despondency, feelings of being overwhelmed, difficulty thinking clearly, and fatigue. The blues typically peak on postpartum day 4 and 5 and usually resolve by postpartum day 10. Baby blues are usually self-limiting and require no formal treatment other than reassurance and validation of the woman's experience, as well as assistance in caring for herself and the newborn. Follow-up of women with postpartum blues is important because up to 20% go on to develop postpartum depression. Now, postpartum depression is a form of clinical depression that can affect women and less frequently men after childbirth. Unlike the postpartum blues, women with postpartum depression feel worse over time, and changes in mood and behavior do not go away on their own. Postpartum depression may persist for a minimum of 6 months if untreated. Different from the baby blues, the symptoms of postpartum depression last longer and are more severe and do require treatment. Some signs and symptoms of postpartum depression include feelings of the following: restless, worthless, guilty, hopeless, moody, sad, overwhelmed, loss of enjoyment, low energy level, and loss of libido. Postpartum depression affects not only the woman, but also the entire family. The cause of postpartum depression is not known, but research suggests that it is a multifactorial component. According to ACOG, postpartum depression is likely to result from body, mind, and lifestyle factors combined. The levels of estrogen, progesterone, serotonin, and thyroid hormone decrease sharply and return to normal during the immediate postpartum period, which can trigger depression and can change a woman's mood and behavior. Postpartum depression may lead itself to prophylactic intervention because its onset is predictable. The risk period for illness is well defined, and women at high risk potentially could be identified using a screening tool. Management mirrors that of any major depression. A combination of antidepressant medication, anti-anxiety, adequate sleep and rest, and psychotherapy in an outpatient or inpatient setting. Assessing partners' postpartum depression is not easy. Nevertheless, it is important for all nurses who have contact with new partners to remain open to the notion that new partners are predisposed to postpartum depression, particularly if their partner is afflicted. Nurses may be most able to help a new partner devastated by postpartum depression when they plant seeds of awareness that the disorder exists, that they are not alone, and that help is available. Screening for symptoms of postpartum depression in both men and women is an important preliminary step to diagnosis and treatment, but the effectiveness of depression screening is dependent on the reliability and validity of the screening instruments in the population. Both the Edinburgh Postnatal Depression Scale and the Postpartum Depression Predictor Scale have been used to screen mothers for postpartum depression, but it is not clear which instrument best predicts a diagnosis of postpartum depression. With postpartum psychosis, this is a severe end of the continuum of postpartum emotional disorders, which occurs in every 1 in 1,000 live births. Postpartum psychosis is an emergency psychotic condition. It can result in a significant increased risk for suicide and infanticide. Symptoms of postpartum psychosis, such as mood lability, delusional beliefs, hallucinations, and disorganized thinking, can be frightening for the women who are affected and for their families. It generally surfaces within 3 months of giving birth and is manifested by sleep disturbances, fatigue, depression, and hypomania. The mother will be tearful, confused, and preoccupied with feelings of guilt and worthlessness. Early symptoms resemble those of depression, but they may escalate to delirium, hallucinations, extreme disorganization of thought, anger towards herself and her infant, bizarre behavior, delusions, disorientation, depersonalization, delirium-like appearance, manifestations of mania, and thoughts of hurting herself and the infant. Women with postpartum psychosis should not be left alone with their infants. Most women with postpartum psychosis are hospitalized for up to several months. Psychotropic drugs are almost always part of treatment, along with individual psychotherapy and support group therapy. Assessing risk factors for these affective disorders is important. Begin the assessment by reviewing the history to identify general risk factors that could predispose a woman to depression. Poor coping skills, first pregnancy, low self-esteem, numerous life stressors, history of abuse, mood swings and emotional stress, previous psychological problems or a family history of psychiatric disorders, substance abuse, limited or lack of social support network are all important risk factors that should be assessed. Be alert for physical findings. Assess the woman's activity level, including her level of fatigue. Ask about her sleeping habits, noting any problems with insomnia. When interacting with the woman, observe for verbal and nonverbal indicators of anxiety, as well as her ability to concentrate during the interaction. Difficulty concentrating and anxious behavior suggest a problem. Also assess her nutritional intake. Weight loss due to poor food intake may be seen. Some common assessment findings associated with postpartum depression are listed in box 22.2 of your book. Nursing management must include the need to educate for the need for nurses to be able to educate themselves about this disorder in order to help facilitate early recognition of signs and symptoms of the condition, which in turn would make early treatment possible, thus supporting recovery. Encourage the client to verbalize what she's going through, and emphasize the importance of keeping her expectations realistic. The nurse can play an important role in assisting women and their partners with postpartum adjustment. Have available referral sources for psychotherapy and support groups appropriate for women experiencing postpartum adjustment difficulties. Have them available to the patient. This concludes our lecture today on postpartum patients at risk. I want to make sure that you guys review those pages in your book that I refer to, and also to just use your this lecture and this PowerPoint to help you guide you in your reading, and to look for the areas that are mostly that are most important out of your chapters. I hope this was a helpful lecture, and we will see each other soon.